Good morning, everybody. I'm Ian. I'm from Singapore. And my presentation today is on health amongst residents of public rental flats, basically reaching hard-to-reach populations in Singapore. Okay, so I'll be briefly covering some background, followed by our intervention, and finally challenges that we face along the way to implementation as well as feasibility. So I'll first talk about the background, which is how home ownership relates to socio-economic status in Singapore. So the majority of Singaporeans actually stay in public housing, which is built by the government, and home ownership rates in Singapore are very high. Almost 87% of Singaporeans actually own their own house. For the needy, those who cannot afford to own their own home, heavily subsidized public rental housing is available, and this public rental housing is built within the same locations as owner-occupied public housing apartments. This is because of land use constraints in very densely built up Singapore. So these are the various housing estates across Singapore Island. So these rental flats are actually scattered across all the various housing estates in Singapore. They are not confined to particular locations. So they actually occupy the same built environment as higher socio-economic status housing. So in our previous studies, what we have demonstrated is that residents in rental flat neighbourhoods do face issues in access to treatment and access to healthcare. So residents of these rental flat neighbourhoods are less likely to seek treatment from medical professionals. They are more likely to seek consultation from friends, family, or even non-medical practitioners, such as practitioners of traditional Chinese medicine. They are less likely to access regular health services, such as cancer or cardiovascular screening. In terms of chronic disease, they are less likely to have control of high blood pressure. And other studies have shown that staying in public rental housing is a risk factor for early readmission to hospital, frequent admission to hospital, and visits to the emergency department. So these differences in health actually persist regardless of whether you stay in regardless of individual socio-economic status as well. If we look at mental health, what we have shown previously is that residents in rental flat neighbourhoods are more likely to have cognitive impairment and also more likely to have depressive symptoms. We postulate that this is because deprived neighbourhoods may have less opportunities for social engagement and interactions that may be protective against poor mental health. So when we talk about individual and the environment, what do we mean? Of course, we have the level of individual, so individual factors such as socio-economic status, your own individual household income, whether you're employed, etc. Then we go on to the micro level, at the level of the household and the home, your immediate living environment. Then we go up to the neighborhood. How far are you away from amenities? How far are you to services? What is the built quality? What is the quality of a built environment? What is the quality of a social environment? And then finally, you go to the macro level, which involves the city and beyond. So what do we know about the impact of the environment and health in Singapore? Do differences in perception of the neighbourhood environment exist in Singaporean public housing estates? And are there associations between perception of the neighbourhood environment and health-seeking behaviours? So these are pictures of a housing estate in Singapore. It's very difficult to tell which is the rental house and which is the owner-occupied house, because these two blocks, one is a rental block and the other one's an owner-occupied block. But as you can see, they look almost exactly the same, and they occupy the same built environment. So basically, the block on the left-hand side of the screen is a rental flat block, but you will never be able to tell that just by inspection of the built environment itself. So when we look at the components of the social environment, there are various factors influencing how we perceive our social environment, but essentially it centers around a sense of community, opportunities of social interaction, opportunities of community participation, and a sense of neighbourhood identity, place, and attachment. So when we look at how social interactions stack up amongst residents of public housing in Singapore And bear in mind that the majority of Singaporeans actually stay in public housing, almost 80% of Singaporeans. You can see that people's social interactions are actually confined to people mainly staying on the same floor as them or in the same block as them. But you talk about different blocks, people only interact occasionally or maybe even never. So therefore, while you share the same built environment, you may not necessarily share the same social environment even though you stay in the same neighborhood. And where does interaction actually take place? Well, it actually takes place very near the home. So it can take place at the void deck. So majority of residents reported interacting with their neighbors in lift lobbies, at void decks, and in coffee shops or retail shops. Basically, these are shops around the neighborhood. So these are the areas that are actually foci of interaction within the community. And these areas are actually very close in proximity to the residents' homes. So at the void deck, so void deck in Singapore basically is an open space at the bottom of public housing blocks. So essentially the residential levels are on floor 1 and above, and on the ground floor basically is an open space that is enclosed, protected from the elements, and residents can meet there for social interaction. So we have some studies in the literature looking at the effect of neighborhood environment and the quality of built environment, but these studies mainly look at the impact of neighborhood walkability and measures of physical activity. They don't look so much at perceptions of health and participation in health services. However, there are differences in social interaction patterns depending on type of neighborhood. So you stay in public housing compared to private market housing, you can see that there is some difference in terms of your contact patterns with relatives and friends. So basically, we sought to look at some of the perceptions in neighborhood environment between residents staying in rental units versus residents staying in own-occupied blocks. So we have three groups, the rental flat units. So these are integrated units on the top. So basically, these rental flat units are integrated in the same block as own-occupied units. Then you have standalone rental blocks, which forms the majority of rental housing. So basically, you may have, say, 1 or 2 rental blocks in a neighborhood of 10 own-occupied blocks. And then you have own-occupied housing, which is precincts composed solely of own-occupied housing blocks. So what we found is that those staying in the rental apartment perceive their neighborhood environment as more disadvantaged, even though the built environment was actually the same. And they also perceive their neighborhood environment as less safe and less convenient, even when controlled for other factors such as their social isolation and their and other demographic factors such as marital status as well. So even though needy residents share the same built environment compared to their more well-to-do neighbours in densely urbanized Singapore, there are still differences in perception of the neighbourhood. And we also found that having poor perception of neighbourhood environment was associated with lower uptake of preventive services such as health screening and participation in regular exercise. So again, although there may be very little difference in the built environment, there is difference in the social environment. So on the left, perhaps so although externally it may be very similar, internally you may have differences such as trash, debris, etc. And in terms of social environment as well, the owner-occupied blocks may have opportunities for social interaction that the rental blocks do not have. So then we move on to our intervention, which basically centered around the premise of, if we can't get residents to come out of their social environment to assess health, perhaps we can bring health into their environment to them. So this is our intervention. So this is what we call the Neighbourhood Health Service. So this is actually a service that is run by the medical students in the National University of Singapore health system. and these are medical students from the National University of Singapore, and I'm one of the advisors helping them. So basically, our focus population is residents of 1 to 2 room rental flats in Singapore. And since 2008, we have served almost 5,000 residents in 9 districts across Singapore. So this is some details on our population. Essentially, the rental flat population tends to be elderly, tends to have less education, and also tends to have lower household income. This is because household income is one of the factors determining eligibility to stay in rental housing. So what we do is that we conduct free health screenings to target rental block residents. So what happens is that the students initially will conduct publicity to encourage residents to go for the screening. Then screening is held at areas close to the residents' homes, so either at the void deck just below, or for residents who are less mobile, the students actually go door to door to visit and find these residents. So within our screening program, we offer a variety of screenings, basically for cardiovascular disease as well as cancer. So we have diabetes, high blood pressure, high cholesterol screening. We also have cancer screenings, fecal occult blood testing for colorectal cancer, pap smear and mammograms for cervical cancer and breast cancer. These are provided with the aid of mobile bus services. We also have dental screening as well, and eye screening. So what happens subsequently is that after screening, we have a follow-up program that lasts for 3 months, in which the medical students will actually make house visits or phone call to follow up residents with abnormal health screening results. And the objective is basically to see whether through providing SS enhanced health screening, whether we can actually link these residents back into the health system and we can link them back to care. So I'll look at the effectiveness. So this is some ecological data that we present. So on the left, we have the rental flat population. On the right, we have the owner-occupied flat population. So this was one specific site in which we were visiting from 2008 all the way to 2014. So we can see that over the years, in the rental flat population, for take-up rates of cardiovascular screening for high cholesterol, diabetes, hypertension, over the years, the rates of participation actually increased from 18% to almost 40% by the end, compared to the owner-occupied flat population. So this is the population staying next door in the same precinct as them, in which rates actually remained quite stagnant over the years that we were involved in this community. Similarly, for cancer screening, for fecal occult blood test take-up, pap smear and mammogram, again, the rates increased from single digits at the beginning of the intervention to almost close to 15 to 20% at the end, compared to rates that were largely stagnant in the owner-occupied flat population. However, we also tracked lifestyle behaviors, and perhaps because our intervention was not so targeted at lifestyle initially, but it was more targeted at access to preventive services, what we see is that over the years, the percentage of those who were overweight, smoking, drinking, or overweight, smoking, and drinking actually increased over the years in the rental flat community, and this mirrored actually increases that we see in the owner-occupied flat population and the general Singaporean population as a whole. Conversely, physical activity actually decreased as well over the years. So perhaps this was because the intervention was focused mainly on screening participation, and it was not so targeted at lifestyle. So what we have seen is that for patients who have known high blood pressure, we are able to increase the treatment rate from 63 to about 90%. And how we do this is by linking them back to care within the primary health system in Singapore. So we work closely with the polyclinics, which are the primary health clinics in Singapore, and residents are given basically appointments and also a free voucher to cover the cost of the initial visit back to the primary healthcare provider. So we have also been effective at improving blood pressure control, and we calculated the social return on investment ratio So it's about $2 worth of value for every $1 invested in our program. However, we do face implementation challenges in this population, and I'll go through a few of these challenges and some of our potential solutions for these. So one of the main things that stands out is that our population is very different from the makeup of our volunteers. So as mentioned, the population that we serve actually is elderly, less educated, and has a lower household income. But medical students in Singapore actually come from usually the higher socioeconomic strata, and of course they are more highly educated and they are young. So it's diametrically opposite to the demographics of the population that they aim to serve. What this does is that it does translate into communication issues. A large proportion of our population speak dialect, various Chinese dialects, and a large proportion of them actually speak other languages like Malay or Tamil, which our medical students may not be so familiar with. So it becomes very difficult to communicate to them because you need to communicate in their language, and the resident usually says, "I don't know what you're talking about." So you can see misperceptions are actually the main reason for non-adherence to screening in this population. People feel that they don't want to participate in screening because they are healthy, they are not at risk, it's not age appropriate, and they've never heard about screen modality. So a lot of this actually is due to misperceptions. There is a public health opportunity, but how do we get this message across? Because patients have all these misperceptions that can be overcome with better communication. So basically how the students operate is that they try to use pictorial aids. They came up with a kit to illustrate how to use a fecal occult blood test involving some brown plasticine, and basically they would try to demonstrate to the residents the process of taking this test. And in so doing, they try to overcome a lot of the perception barriers that residents had towards this particular screening modality, because a lot of residents felt that this test was dirty, it was not clean, they had to touch fecal material, they're not comfortable with it, etc. So the students actually had to overcome some of these misperceptions and these barriers. But it is challenging. We look at the health beliefs pre and post intervention. So you can see that a large proportion of residents actually feel that they don't need this test because they're healthy, they're not at risk, and they don't show much screening modality. And these issues actually still persist post-intervention, so the perception is largely unchanged. So it is difficult to change long-standing beliefs, especially if you're not familiar with their language. The next issue is also trust building. So this was an email that we got in 2012 from the police. So essentially what happened was that basically the residents were suspicious of the presence of strangers in their neighborhood. So they actually called the police. We never received a letter in subsequent years. But this is an example of how there is actually a need for trust building in this community, because they are suspicious of strangers, and rightfully so, because of various scams and various crimes that targeted the elderly and the low-income population. So basically there is a need for immersion within the community. So what we do is that basically the medical student actually is brought into the patient's residence to experience the lived environment of people staying in these communities. And what it did show is that it helped the residents, the students, to see a different side of Singaporean society, and also help them to understand the lived reality of Singaporeans, low-income Singaporeans, when accessing healthcare. And this sort of home-based program was actually superior to a similar service learning program that was based in areas of high human traffic, like shopping malls or public transport nodes, in helping the students appreciate challenges to healthcare faced by the lower income Singaporeans. We have communication courses for our students in order to help them speak dialect and other languages to communicate better to residents. because it's very important that you need to communicate with the low-income residents in languages and terms that they're familiar with. So we have to engage community partners as well. We have a lot of community partners that support our work. Yep. So conclusion is that it's possible to engage the low income, but it needs time to be immersed in their lives, to understand the language and this living situation, and we need to get buy-in from our local partners as well. Yep. So I'd like to acknowledge our partners and of course the various student committees that support this screening, and I thank you for your kind attention. I'm happy to take any questions.